Thanks for joining in for the episode 2 of Pulmonology Read Aloud series, where we are talking about the AHA ACC Guideline on Acute Pulmonary Embolism. In the previous video, we have already initiated the discussion of this guideline by talking about how we can screen patients based on clinical predictors for pulmonary embolism severity. In this second part, we are going to learn whether we should be sending our patients home or admitting them in a particular facility. What should be the treatment directed to the patients for acute pulmonary embolism? We would be talking about thrombolysis, we would be talking about advanced ways of thrombolysis, and we are going to again go through our patient, which we discussed last time, to understand how to apply these guidelines clinically. So let's get started. Previously on Pulmonology Read Aloud, in episode 1, we talked about 58-year-old patient Mrs Mehta who came with sudden severe pleuritic chest pain, acute dyspnea, who had a well score suggestive of a likely PE, a revised Geneva score suggestive of intermediate probability, and a high D dimer, along with an age specific modified D dimer also being high. We saw how, when we are approaching any patient with chest pain who has a high or an intermediate probability of pulmonary embolism, a test like D dimer has to be added to the clinical severity score to rule in or rule out a pulmonary thromboembolism by means of utilization of imaging in the right case. In case you haven't seen the previous episode, you will learn how and when should we suggest imaging for patients suspected of pulmonary embolism. Now, our patient has had acute pulmonary embolism confirmed on CT pulmonary angio. Let's move ahead and understand what to do next. So, for our patient has an acute bilateral pulmonary embolism confirmed on CTPA, the question is, where should we admit this patient? Her saturations are fine. She looks relatively stable with a stable blood pressure. Should she be admitted in the ward, in the ICU, or should we directly go ahead and do thrombolysis for our patient? This is what we are going to understand with our guideline. So, today, after achieving the diagnosis and risk stratification, we have to take a call on admission, admission strategy, and on reperfusion. So, now the most important flowchart, which is given in this guideline paper, comes into picture. The recent acute PE clinical categories. This is the latest addition in managing pulmonary embolism, and this classifies patients into 5 categories, A to E, so that we can take a clinical call based on patient severity. When you look at these clinical categories, you see that category A has subclinical patients with incidental asymptomatic P. These are the ones with the lowest risk. And as you go up the category, the risk increases. So from subclinical asymptomatic to symptomatic but with a lower clinical severity score, further to symptomatics with elevated clinical severity scores, then those patients who have an incipient cardiopulmonary failure, and finally in category E, patients with cardiopulmonary failure. Now, whenever these patients meet these criteria and there is a respiratory modifier, then a prefix of or a suffix of R is applied to the category. So, if there is a respiratory modifier, then we add C3R or D2R. And here we divide B, C, D, and E into further categories. So this is the R respiratory modifier, which we apply to category C, D, and E, which means a low saturation, less than 90, a high respiratory rate, or a need of supplemental oxygen, which can again increase in severity. Now, for category A, there is no subcategory, but for category B, symptomatic, there are two subcategories, B1 and B2. B1 is subsegmental, single or multiple emboli, and B2 non subsegmental. Category C is divided into three categories based on RV function. So, here echo is very, very important. So, here we talk about C1 as patients with normal right ventricular and normal biomarkers, C2 as abnormal right ventricular or more than one abnormal biomarker, and C3 abnormal RV and more than one abnormal biomarker, plus minus the respiratory modifier. For category D, the two subcategories are transient hypertension or normotensive shock. Again, plus minus the modifier. And here we are expecting that the patient is on oxygen with incipient cardiopulmonary failure. So we talk about oxygen as 6 liter or more nasal cannula or use of a non rebreathing mask. For patients in profound cardiopulmonary failure, the two categories are E1 with recurrent or persistent hypertension with cardiogenic shock, and E2 refractory cardiogenic shock or cardiac arrest. And here the modifier is hypoxemic respiratory failure or patient on ventilator. Don't worry, we'll be talking about all these terminology in our subsequent slides. What I want you to understand is that based on the clinical severity score, the PESI or the HESTIA, we are going to decide which patient of ours is in category A to E. And then, based on the investigations or the hemodynamic profile, we are going to give him a subcategory. So now category A, which is the least severe, to category E, which is the most severe. This decision is typically identified after we have already done a CT scan and we have also done clinical severity scoring. For now, we have to remember that suppose a patient with category A1, category A, has an asymptomatic subclinical P, which was found with a diagnosis secondary to doing a CT scan for a lung cancer and finding a left lower lobe subsegmental PE on a cancer staging chest CT scan. Now, this patient may not require admission for the PE. This patient is asymptomatic. So, here our management will change. Vis-a-vis a patient who has been diagnosed to have pulmonary embolism based on his clinical presentation. Hence, the categorization is of great help to understand how to approach a patient. When we move up the ladder and we reach to symptomatic patients in category B and C, we see that while B patients still have a low clinical severity score, patients in C category have a high clinical severity score. So their PESI is more than 85, or their simplified PESI is more than 1, or their HISTIA is more than 1. These are symptomatic and they also have an increased risk of adverse outcomes. So, this group of patient is someone we have to be very, very careful for. And because there is an inclusion of the biomarkers and the echo profile in this category, it allows for recognition or absence of cardiopulmonary dysfunction. What are the biomarkers that we should do? We'll be talking about it in the coming few images. Now, when we go on to category D, we see that these patients have incipient cardiopulmonary failure. So, we are dealing here with patients who have a pre-cardiopulmonary failure status. For example, a normotensive shock, or we are approaching the need for ventilatory support, but we are still not there. The subcategories which are done here, which divide the patient into transient hypertension versus normotensive shock, These subcategorizations are trying to differentiate the cardiovascular and pulmonary compromise. So, category D1 will identify somebody who has transient or recurrent hypotension, which can be relative to what the patient presented with, which may be short lived, which responds well to volume expansion, and is not accompanied by reduced perfusion or signs of end organ dysfunction. But when you move on to category 2, that is normotensive shock, and this requires markers of decreased perfusion or end organ dysfunction. For instance, now showing signs of acute ischemic kidney injury, or now showing persistent lactate elevation and the transient hypotension. A lot of times we give a trial of IV fluids while we are having transient hypertension in patients. And here, a trial of an IV fluid would be generally 500 to 1000 ml of IV normal saline. This will help us define whether the patient has a transient hypertension which responds or not. Again, the importance of shock scores is very important, and a shock index has also been given by the guideline paper, which is heart rate divided by systolic blood pressure. So, whenever we have higher shock scores, we are moving up the ladder of the clinical categorization. For example, if we have a patient in category D2, acute pulmonary embolism, and this patient has undergone, say, a spinal surgery and has now come with dyspnea, tachycardia, hypoxia, but a normal systolic BP with a CTPA diagnosed pulmonary embolism in both right and left main pulmonary arteries, but also showing end organ perfusion problems in the form of rising creatinine or lower MAP. Then this patient who's in category D is in imminent cardiopulmonary failure. And here, if he's on oxygen, you will apply the respiratory modifier. So here, this patient's category becomes a D2R. The most severest of the category, which is category E, is focused on cardiopulmonary failure. And here the subcategories are differentiating the patient with a recurrent persistent hypotension, which is a hemodynamic collapse, with cardiogenic shock, from patients those who just have a refractory cardiogenic shock or cardiac arrest. Category E1 is actually compatible with shock stage C, and category E2 is defined as a refractory cardiogenic shock, which is a SCAI shock stage D or E. So, respiratory failure category E, may require non invasive or invasive positive pressure ventilation, and these are the patients who are most severe. Let's apply the categories now to our patient, Mrs. M. For our patient, her BP is still normal. She's not in shock. She doesn't have a cardiac arrest. So the question arises, which category do I place my patient? Think of the answer while we move ahead. Now, for our patient who did not have shock but was symptomatic, you probably would have placed her in category C. For this patient, when you look at category C, you will remember that we are talking about RV dysfunction and we are talking about biomarkers. So let's look at her results. Her troponins are positive, her proBNP is elevated, the echo has been done, and she has an RV dilatation, RV-LV ratio more than 1, with septal flattening and a moderate RV dysfunction. So clearly, this patient has positive biomarkers, and this patient has evidence of RV dysfunction along with being symptomatic. So, with this criteria, when you look at it, our patient who's symptomatic, having an abnormal RV, and raised abnormal biomarkers, this patient would be in category C3. And for her to be having a normal SpO2, the respiratory modifier is not added. So for this patient, she is in category C3 with abnormal RV, more than one abnormal biomarkers. So a C2, C3 category and that's how we will take her final decisions. Now, coming to further decision making, the role of the clinical risk scores has already been discussed in the first episode. But you need to remember that the recommendations categorically say that for patients who are diagnosed with acute PE in category A and B, you can use the Hestia, PESI, or simplified PESI score. For patients who are hemodynamically stable but in category C and D, you must use a validated score, and that is reasonable to identify who is at higher risk of short term adverse outcomes. So, for our patient, she is at a risk of higher adverse outcomes, and that is defined through this recommendation. Thirdly, they talk about a new score. The new score is National Early Warning Score, and there is a new updated version for this score, the News 2 score. This score is also given in the list of the scores recommended by the guideline, and they mention as a 2B recommendation that in hemodynamically stable patients with acute PE in category C and D, you can also do the news or the news 2 score as an alternative to P specific risk score. And where does it come from? It comes from an article which was published in Archivo di Bronchopneumologica, where they discussed that when you compare News 2 versus simplified PESI, both predict complicated outcomes, and the simplified PESI can identify better low risk pulmonary embolism. So, for categories C and D, you can also use a score called the News score. Coming to the second aspect, which is biomarkers, because in category C, like Mrs. Mehta, we need to know whether the biomarkers are elevated. So, what do we do about that, and which are the biomarkers? So, the recommendations say that in patients with acute embolism and elevated clinical severity score, but no hypotension or shock, so hemodynamically stable like our patient, like category C, measurement of at least one cardiac biomarker like troponin, BNP, is recommended to assist the risk stratification, and that's exactly what we are doing. They also say that in patients with acute PE who are now from the severity category, category C to E, who are undergoing evaluation in an acute care facility, measurement of lactates, either venous or arterial, is recommended to assist risk stratification. So, what would you do? You would do troponin, you would do BNP, and you would do lactate. Now, coming to echo, and echo is really important because as you see, for category C, there are only two things which are required, the biomarker and the echo. So, why is echo so important? More than even looking at the clot burden. Now, echo is more important than a CT scan clot burden because that is going to tell us about short term risk stratification. It has been seen that RV hypokinesia is associated with a four-fold increased odds of PE related mortality. And that is why the guideline paper mentions the importance of using the parameters of RV dysfunction. RV dysfunction on an echo will correlate with increased odds of all cause mortality for your patient. And amongst the patients with pulmonary embolism who are found intermediate risk of adverse outcomes, RV dysfunction on echo is very important because it will also tell you about the mortality. So, the current data and the current guidelines do not incorporate measures of thrombus burden on a CT score. And these include certain scores like the Miller score or a refined Miller score, but they include right ventricular function. So, an anatomic characterization of thrombus burden is not always necessary. If you have it, It tells you about the feasibility, the safety of what therapy you will use, whether you use advanced therapy like catheter directed thrombolysis. But for categorization of risk, you need a RV imaging. So the guideline says that grade 1 evidence is, and the level of evidence is A here, very important, that in patients with acute P and elevated clinical severity score, but without shock, like our case with category C to D, RV imaging is recommended for short term risk stratification. And for patients with an elevated clinical severity but no shock, like our patient, the use of echo over CT is preferred for short term risk stratification. Echo over CT burdening. So, CTPA is essential for diagnosis, but we are not talking about the clot burden. We are talking about echocardiography being preferred for short term risk stratification. So, what is the guidelines notification on thrombus burden? Level 3. The recommendation is grade 3, no benefit. So, in patients with acute PE in category A to C, quantification of angiographic thrombus burden for short term risk stratification is not recommended. So, for A to C, you would not depend on the clot burden or the thrombus burden to decide whether this patient needs an ICU, needs therapy. You would go and do a echo for RV imaging. Now, then comes the hemodynamic assessment. And what do the recommendations say? There is a grade 2 recommendation of patients in acute PE with category D2. So, patients with incipient respiratory, cardiorespiratory failure, evaluating for the presence of normotensive shock can be useful to identify those who are at increased risk of clinical deterioration and in hospital death, which tells us that if your patient has normotensive shock, you evaluate it, you can identify which patient can deteriorate. So essentially it tells you where to place your patient, and it solves the problem whether you need a ward admission, you need to send him home, or you need an ICU admission or an HDU admission. What is this normotensive shock? The normotensive shock means that there is isolated hypoperfusion with any one of the following: lactates, serum lactates more than 2, a urine output which is low, less than 720 ml in 24 hours, a creatinine which rises more than 0.3 milligram per ml in 24 hours, or a reduction in cardiac index less than 2.2 liter per minute per meter square from peripheral arterial and mixed venous oxygenation saturation values. So, when you are doing an ABG or a VBG or a mixed venous analysis, and you're seeing higher lactates, you are seeing that your patient is oliguric with less than 720 ml output in 24 hours, his creatinine is rising, his cardiac index is falling, then you would call it a normotensive shock. And so, in these group of patients, we can say that these patients are at higher risk of clinical deterioration. Secondly, they say that in patients with acute embolism, in category C3, where the biomarker was elevated and there was RV dysfunction, a map of less than 80 may be useful to identify patients who may require escalation of therapy. So, escalation of therapy would probably mean moving on from anticoagulation to thrombolysis, and this we'll discuss in our next segment. Then they also say that again, this thrombus burden is not going to decide our parameters. So, coming to another very, very important flow chart from the guideline paper, what do we do now and how do we manage our patient once we have these clinical categories?